I would like to start with a very positive announcement. Um, as you know, NF2 BioSolutions, we support different approach, innovative approach to tackle NF2. We have gene replacement therapy, we have bacterial therapy, and we have also the suicide gene therapy. And we are very happy to announce to you that Merlin, that is taking forward this suicide gene therapy research, received a 3 million grant for moving this forward up to the point where we get the IND. It means the permission to run a human trial. So that's a very positive um, news for us. We need a lot of your support to continue this series of webinar, but also to move forward the other approach. We have the NF2 gene replacement therapy that we started a few years ago from scratch at Nationwide Children's Hospital. And now we are going to launch a new fundraiser to move it forward so we can start to produce the AAV9, the virus that can transmit the NF2 gene and replace the NF2 gene, the defective NF2 gene in the tumor. And for that, we need to raise $850,000 during in the next few months. So please, anything you can donate or put us in contact with some donors that you have in your network, and we will be happy to receive this help. I would like to introduce you Dr. Matthieu Peyre, that is going to talk today about the NF2 peripheral tumor. Dr. Peyre is a neurosurgeon and a lecturer at the Department of Neurosurgery at La Pitié-Salpêtrière in Paris. He specialized in the surgical management of peripheral nerve tumors, that includes schwannomas, as well as aggressive form of meningiomas. His research focused on benign brain tumor and malformation, with emphasis on the molecular biology of this tumor and the development of genetically modified models to study their origin and progression. Myself, I have a daughter with NF2, and she has peripheral tumor in the clavicular area, and that's how I met Dr. Peyre, that he tracked the tumor of my daughter, and we are currently in the process of evaluating what should be the next step. So I hope that this webinar will be very good for you, for your personal knowledge about peripheral tumor, or it can also answer to questions that you have in your specific cases. Thank you. Dr. Peyre, you can start. I will and share my slides.
Thank you, Mr. Atlan, for the nice introduction. So I will indeed share my slides and do my presentation that will be about the peripheral nerve tumor management in NF2-related schwannomatosis. So as you will see during the talk, I will not only talk about tumors, but also other problems of the peripheral nerve system in NF2-related schwannomatosis that may also give a very important burden in terms of neurological deficits in the patients, which are the neuropathies, and that are less well known than nerve tumors, but we'll come to that in a few moments. So first, I will give you a presentation on peripheral nerve schwannomas in a general context and not in the context of NF2-related schwannomatosis, just to let you know how these tumors are discovered and how they are treated in the general populations. And then in the second step, we'll come to the specific cases of NF2-related schwannomatosis. So just for the presenting symptoms of those tumors, so they're sometimes only seen by the patients as a palpable swelling along the nerves. So they do not cause always pain at first. So they're just like a bump on the limb, a leg, an arm. So it's not always a big deal. And patients may live for several years with these lumps, and they do not cause any harm. But when they compress the nerve fibers, they may cause pain, so local pain, or paresthesia, which means tingling along the nerve territory. So when you have a tumor, for example, in the thigh or in the back. It may cause pain along the nerve territory to the leg and to the foot. So it's always a big deal to try to guess where does the pain come from to be able to alleviate the pain adequately. So one of the particular things that you find in peripheral neuroschwannomas is that you have an intensification of the pain at night, which is found in 25% of cases. So it allows us to determine if the pain comes from a schwannoma or if it comes from another cause, because as all people, NF2 patients may have pain from different causes. The tumor is usually firm and it's quite mobile, perpendicular to the nerve pathway. And there is a Tinel sign found in about 2/3 of the cases. So a Tinel sign is the fact that when you hit the tumor with a hammer, for example, or with your finger, you may reproduce the pain that the patients feel spontaneously and particularly at night. And it's also a way to determine that the pain comes from the tumor. And as a surgeon, it gives us a confidence that we will be able to release the pain when we take off the tumor because we have this sign at examination. Otherwise, the physical examination is usually normal, which means that the patients, they do not have any sensory or motor deficit linked to schwannoma. And particularly, the preoperative motor deficit is present only in 12% of cases. And we'll see exactly which cases we're talking about later on in the presentation. So when you get a peripheral neuroschwannoma, what do you do? Basically, you can start with an ultrasound imaging. So in NF2 clinics, it's something that can be done during the outpatient clinic. So it's quite quick. For example, the patient comes to your clinic, he says, "Oh, I have a pain in my arm, a pain in my foot." You can do the ultrasound imaging right away, and then you can localize the schwannoma that appears as a mass, as you can see on the right. And you can also see the nerve coming in and out of the schwannoma. So it's a nice way to identify the tumor causing the pain quite quickly. Of course, the main exam to make a diagnosis of a peripheral nerve schwannoma is MRI, when you see a mass centered on the nerve trunk. And you see an example here of a ulnar nerve schwannoma in the arm. And there are lots of signals on MRI to be sure that it's a schwannoma. But in NF2, there's not a differential diagnosis, and those tumors are almost always, if not schwannomas, but we'll also come to that a little later. When patients have several pains, when they feel pain in several limbs, sometimes you can do whole body imaging to try to assess the overall tumor burden. So it can be done in 1.5T or 3T MRI. And the main sequence to do that is the STEER sequence, when you see an example here on the right. So it's a nice way to have a global view of the tumor burden of the patient if patients have several points of pain, but it remains quite cumbersome and prone to artifacts. An alternative would be the whole body PET MRI, which allows a more precise view of the schwannomas. And there was a small study done in France comparing whole body MRI, PET CT, and whole body PET MRI imaging. And you see here an example of the tumors that were seen in the different patients. And you see that when you use whole body imaging, and in particular whole body PET MRI, you see a slightly higher number of tumors. So it allows a better detection of tumors, especially the small tumors that you can see here as bright spots on PET imaging. So it's not mandatory, but it can be an help for the clinician and for the surgeon to detect a whole tumor in the patients. Otherwise, apart from this clinical exam and from the MRI, there is not that many exams that need to be done before surgery in particular. The electromyogram is not routinely requested because it's often normal and it's due to the small number of nerve fibers that are actually involved in the schwannoma. And the preoperative biopsy is really not recommended because it can cause a significant risk of fiber damage. It causes a lot of pain, and it can also modify the cleavage plane due to scarring during surgery. So it's, of course, never requested in cases of NF2-related schwannomatosis. So when you've discovered a peripheral nerve schwannoma in a sporadic patients or in NF2, what can you do? In most cases, you can choose only to do a clinical workup and a regular MRI in case of asymptomatic schwannomas, and regardless of tumor size, meaning that it's not that because the tumor is bigger that it can cause more harm to the nerve. So it's not a problem to wait because in most cases the nerve won't be damaged by the tumor. So it's better to wait if the tumor causes no symptoms. So um, even if you have radiological growth, you can still do this surveillance. And we do, in most cases, annual MRIs, also depending on the rate of tumor growth. Surgery is recommended when you have appearance of painful symptoms, and especially when you have functional discomfort considered significant by the patients. So there is a lot of conversation with the patients to make sure that there's a real need for surgery, to be sure that it will alleviate pain or increase the quality of life of the patient. And it's something that we discuss for every schwannoma with every patient because everyone is different. So we have to be sure that it's going to be beneficial to the patients in the end. One particular thing in NF2-related schwannomatosis is that sometimes, as you know, you don't find the mutation in the NF2 genes in the blood of the patients. But patients want to know if they carry a mutation and if they can give these mutations to their children. So if you want to do an easy molecular diagnosis for NF2, taking out a small schwannoma under the skin may be a good strategy because the surgery is safe. You don't have any major risk, and you can analyze the NF2 mutation inside the schwannoma and then give the information to the patient and his or her family. So it's not something that we do very often, but you may keep that in mind if you ask yourselves if you don't know your NF2 mutations and you may have a small schwannoma under the skin that may be amenable to an easy surgery to answer this question. So then I will talk to you about surgery itself. So first you have to understand that the schwannoma, although it's developed inside the nerve, it's only developed at the expense of a single fascicle. And you have to see the nerve as I would say, as an electric cable. As you see here on this drawing, when you have a membrane around the nerve and inside the nerve, you have several groups of nerve fibers, and the schwannoma will be developed at the expense of only one of those groups. So if you manage to do the surgery without harming the other fascicles, you can take out the schwannoma of the nerve without having any motor or sensory deficits. So here are some examples of schwannomas seen during surgery. And as you see quite easily the nerve above and below the schwannoma. And for some cases, as you can see on the right, you can easily see the normal nerve fibers that are coming on one part of the schwannoma. And if you respect those fibers and only take out the tumor on the part where there are no fibers, you will not harm the nerve and you will not cause any problem to the patient. So what do we do? I don't want to get too much into details, but just to let you know how we proceed. We make a small incision in regard of the schwannoma. We use the ultrasound imaging during the surgery to make sure that we make the smallest incision possible just on top of the schwannoma. And it's particularly useful when you have schwannomas inside the muscles, because due to the muscle, the schwannoma may move inside the muscles along with the muscle fibers. So having an ultrasound imaging during the surgery make you sure that you will find the schwannoma inside the muscle, that you will not harm the muscle fibers, and that you will do the surgery with the less harm possible to the normal tissue. So we then dissect the nerve above and below the tumor, and you see here on those small straps that we put the normal nerve to be sure to know where it is and not to harm it. Then we do a coagulation of the nerve outer layer, which we call the pseudocapsule, in a non-functional area. And a second important thing of the surgery, when you do surgery for peripheral nerve schwannomas, is you have to monitor the nerve while you're doing the surgery. So I told you that the electromyogram was not very useful before the surgery, but during surgery, we can do an electromyogram, meaning we can put some needles inside the muscles that are controlled by the nerve. And by doing so, we are able to detect by stimulation that the muscles are working well, and be sure that while we're taking the schwannoma out of the nerve continues to work correctly and that the muscles won't be harmed during surgery. And as you see, when we are able to determine the cleavage plane between the tumor and the nerve, we'll be able to take the tumor out in total, unblock excision of the tumor, which means that there is a very low risk of tumor relapse. So it's not like other tumors that you can see in NF2 when you can have recurrences. It's very rare to have recurrences in peripheral nerve schwannomas. So here it's a drawing of the surgical technique just to make you understand that the schwannoma is inside the nerve, but it's surrounded by normal nerve fibers. And if we use the right technique, we can take the tumor out with the normal nerve fascicle without harming the normal nerve fibers. And as the nerve contains a lot of fibers, you have to understand that when you take out the small entering fascicle and you cut it, you cannot create any deficits because this small fascicle doesn't have any function. It's all other fascicles that generate the sensation, the motor strength. So it's not a big risk. It's not even a risk to cut this small fascicle, and it allows you to make this en bloc excision and to take the tumor out without any problem. So here are just some photograph of the different steps of the surgery that I mentioned for an ulnar nerve schwannoma. So the dissection that allows the detection of the entering fascicles here under the instrument, and it allows an unblock excision with the respect of the normal nerve. How do we do this surgery? So as for anesthesiology, most procedures are performed under general anesthesia. Why do we do that? It's first for an accurate motor testing. As I told you, we'll be able to do nerve stimulation more easily if the patient is not awake. And it's particularly important when we are operating on major nerves. It also allows for a precise postoperative evaluation, because if we do a regional anesthesia, for example, you're operating on the sciatic nerve at the thigh or at the level of the knee, you make an anesthesia of the sciatic nerve at the level of the buttock. After surgery, the anesthesia will still work and you may have a deficit that will be due to the anesthesia. So you won't be able to tell the patient if the surgery went well or not, because the patient will have some numbness in his foot or in her foot, and you won't be able to test to say if it's linked to the surgery or links to the anesthesia. If you do a general anesthesia, you can, right after the surgery, do a full examination of the patient, see that every motor muscle is working well, that there is no numbness, and you can reassure the patients that everything went fine and that he or she doesn't have any deficit linked to the surgery. Although we're doing a general anesthesia, we do this surgery as an outpatient surgery for the majority of cases. So the patient come at hospital in the morning and they leave at night. And the only cases where we keep the patient in the hospital a little longer is the brachial plexus and the pelvic surgeries, because the incisions are quite more important. There are more vascular encasements. So we prefer to keep them in the hospital 1 or 2 days after the surgery. So I'll talk to you about surgery, which is you would say normal because I'm a neurosurgeon. But what are the alternatives to surgery in the case of peripheral nerve schwannoma? So if you are an NF2 patient or if you have NF2 patients in your family, you know that for vestibular schwannomas, you can do gamma knife, that you can use Avastin, bevacizumab. But unfortunately, for peripheral nerve schwannomas, it's not the same. Bevacizumab, in my at least experience, is not working very well. And the other options are percutaneous radiofrequency ablation, but it's been done very rarely in the literature with only 8 cases reported to date. There was one case with a moderate tumor shrinkage with some pain relief, but there was also some cases of possible post-procedural pain. So I wouldn't recommend doing those percutaneous ablations unless, of course, the patient doesn't have the general conditions to undergo an anesthesia. Radiosurgery, also, there are only a few series reported in the literature, not for peripheral nerve schwannomas and mostly for spinal schwannomas. And once again, the effect on pain is very difficult to assess because the indications for radiosurgery were mostly growing of those paraspinal schwannomas. So we don't really know if radiosurgery is efficient on pain. So unfortunately, I would say the only solution for those peripheral nerve schwannomas is surgery, of course, with nerve monitoring and under the microscope. So I have now finished the first part of my presentation on peripheral nerve schwannomas in general, and I will now talk to you about the specific cases of NF2-related schwannomatosis. So I will talk to you about the patients that I treated because I published in 2023 a series of 105 schwannomas operated in 34 NF2 schwannomatosis patients with an average age at diagnosis of 26 years. So you see here on the right where the schwannomas were located. So I operated a lot on patients that had schwannomas inside their hands, on the collateral nerves of the fingers, and that were causing quite pain or discomfort. But there was also a lot of other nerves that were operated, including nerves of the arms, the medium, the ulnar, and the radial nerve, some brachial plexus, and also a lot of nerves of the leg, including the sciatic nerve trunk, the fibular nerve, the tibial nerve, and the sural nerve. So we can virtually operate on any nerve, but it's always a balance between the benefits and the risk. So the symptoms were mostly, as you see, pain and paresthesias that were the most frequently associated symptoms. And as I told you before, for sporadic cases, motor deficits were very rare in this population. And after surgery, we saw some pain resolution in 97% of cases. So the patients were quite happy with the surgery. But we saw a big difference depending on the radiological presentation of the symptoms. Because in fact, for the first time, we demonstrated that there were two kinds of peripheral nerve schwannomas in NF2. There is this regular case of mononodular schwannomas that represent 90% of tumors and that are operated without any major risk because you see that the rate of postoperative deficit is quite low. But there are 10% of multinodular schwannomas, and for those patients, the risk of postoperative deficits is very high because when you try to take out several tumors in the same nerve, at each time that you take out tumor nodules, you cut a small nerve fibers. So if you cut only in one fascicle in the case of a mononodular schwannoma, it's not a big deal. But when you cut 5, 6, 7 fascicles in the same nerve, you may cause a postoperative deficit. So here are some examples of the schwannomas that were operated. So you see in the hand, in the leg, in the brachial plexus here, and here in the median nerve in the hand. We had some cases when we combine a decompression of the nerve with the surgery of a small schwannoma. Like you see here on the right, it was a patient with a pain in the ulnar nerve, and the nerve was compressed here at the elbow, and there was a small schwannoma inside. So we did both a nerve decompression and a removal of the schwannomas to alleviate the pain. You see here the examples of multinodular schwannomas that I talked to you about a little earlier. So you see here a big tumor mass in the shoulder. So here it's not a big deal to operate on those kind of tumors because they're not in a major nerve. So even though they are multinodular, they do not cause any deficits. But it's a bigger deal when you handle some multinodular schwannomas of the brachial plexus, or like here, a multinodular schwannoma of the radial nerve. So it's something that you have to take into account, both as a surgeon and as a patient, that not all schwannomas in NF2 are the same, and you have to pay attention to the MRI appearance of the schwannomas. Another thing that you have to take into account with NF2 are the neuropathies in NF2-related schwannomatosis. So what is a neuropathy? A neuropathy is a disease of the nerve itself. It means that when you look at the nerve, even under the microscope or on a regular MRI, you don't see any major problem in the nerve, but the patients will feel deficits linked to the neuropathy. And as you will see, it's mostly motor deficits. And those are caused by a problem of the nerve itself. So the neuropathies, they were first described in 2002 in a mostly severe form of NF2-related schwannomatosis, with an age at onset before 20 years. You see 9 cases out of 15 patients. And there was a lot of signs of neuropathy, clinical signs, with a lot of muscle wasting. And there were also electrophysiological signs of neuropathy, which means that the electromyogram in those cases was not normal. So electromyogram in NF2 is very important when you have a suspicion for neuropathy, but it's not helpful when you're dealing with schwannomas, and particularly peripheral nerve schwannomas themselves. So in our series of NF2 patients with peripheral nerve schwannomas, we had 6 cases of polyneuropathies. So there were 2 forms. The one that is called axonal pseudo-CMT neuropathy, that was the most frequent. And as I told you before, those are very debilitating neuropathies because they create limb amyotrophy with muscle wastings in the hands, in the calves. So people have difficulties to walk. They have difficulties to even use their hands. And it's not linked to the schwannomas or meningiomas compressing the brain or the spinal cord. It's linked to the disease in the nerves themselves. So it's something that the clinician has to be very aware of, because otherwise you will look for meningiomas, for schwannomas, for ependymomas, causing compression of the spinal cord or the brain inside the head or in the spine, but the problem will be in the nerves themselves. So it's something that has to be very accounted for in NF2-related schwannomatosis. And when people, and especially our German colleagues, have had a big interest in those neuropathies, they were able to perform a very precise MRI of the nerves. And they were able to demonstrate that inside the nerves of NF2 patients, you have in fact small lesions that are not tumors exactly, but are small, I would say, spot signs inside the nerves, and that are mainly or a remnant or a signal of the underlying neuropathy. So we don't do this MRI regularly in clinics because the myogram will be what is more interesting, but it's something that you have to consider when you have some muscle wasting or some symptoms in the patients that you don't know of. Doing those MRI with nerve imaging. Um, so the conclusion for those neuropathies is that even in the presence of tumor, patient symptoms may be related to the underlying neuropathy. So especially when you have a muscle wasting in a patient and the patient talk to you about a schwannoma next to the site of amyotrophy, you have to be very aware that schwannomas very rarely cause amyotrophy by themselves. So it's important not to operate the patients for a schwannoma to try to save, for example, his hand or his foot, because it won't work, because the deficit will be linked to the neuropathy and not the peripheral nerve schwannoma. So it has to be investigated, of course, this neuropathy through a dedicated electrophysiological examination and through the imaging of the nerve to look for those associated microlesions. And it has to be done, of course, before scheduling surgery for peripheral nerve tumors. Otherwise, you may think that it's the tumor that is causing the symptoms. Another thing that you have to pay attention to when you care for NF2 patients, it's very rare, but it has to be taken into account, is another form of tumor which are called perineuriomas. So perineuriomas are very, very rare tumors, but they have a very specific clinical forms because they are revealed by motor deficits like neuropathies, but it's mostly local deficits. It's not a muscle wasting of the whole hand. It's mostly linked to one nerve. And there isn't, contrary to schwannomas, there are no pain, no sensory symptoms. And when you look at MRI, there is a very similar presentation on MRI compared to schwannomas. So you may be tempted as a surgeon to operate on the tumor to try to take the tumor out. But when you operate on the tumor, and it's the pictures that you see below, you don't see a mass inside the nerve, as I showed you before for schwannomas. You see a thickening of all the nerve fascicles. So it's the image that you see below. And for that, you cannot take the tumor out, because if you try to take the tumor out, it's like you're taking the nerve out. So it's causing an even more bigger deficit than the patient had before. So it's something that as a surgeon, you have to be very conscious about, even though it's very rare, because we had only one case in the median nerve in our cohort, and there are only two other cases reported in the literature. So it's not something very common, but as I'm talking to you as a NF2 patient or people whose family has NF2, it's something that needs to be known. We will now very quickly look at specific clinical forms of those tumor. So first, in peripheral nerve schwannomas, I also include what I call radicular paraspinal schwannomas. So when surgeons operate on a spine schwannomas, they most of the time they talk to you about the tumor that are inside the canal, which means that they're surrounded by the bone and they're in the middle of the nerves or next to the spinal cords. But in NF2-related schwannomatosis, you also have schwannomas that are outside the canal, that are next to the spine, and that may cause the pain as much as another peripheral nerve schwannomas. So it's important to know about those tumors because they are exactly like the other peripheral nerve schwannomas, meaning that you have the same indications and principles of surgery. When you operate on those tumors in the spine, the motor fibers, they're actually most of the time close to the belly of the patient. So when you go from the posterior, from the spine, from the posterior part of the spine, you have a very low risk of harming those motor nerve fibers. So you can do a complete resection of those tumors without spinal instrumentation. And it's something also that the patients have to be aware of, because if they have some pain linked to that kind of tumor, they should know that they can have surgery, and that surgery is not as risky as other surgery, and it doesn't need a spinal instrumentation, so it may be a very minimal invasive surgery. Also, another form of peripheral nerve schwannomas in NF2 are the dumbbell schwannomas. So the dumbbell schwannomas are schwannomas that are mostly originating from the neck and that are going inside the spinal canal through the foramen, which means that they have this form of dumbbell that you can see here on the right. So they can both compress the nerve and the spinal cord when they go inside the canal. So the specificity of NF2 is that patients may have a lot of tumors. So you may see a combination of radicular and intracannular schwannomas. But as I told you about paraspinal schwannomas, the principles and the indications for surgery remain the same. And the fact that you can operate on the peripheral nerve tumors before going in the canal and operate on the tumor next to the spinal cord, it makes the surgery safer and easier for the surgeon. So, for example, here on the lower part, you see a big schwannoma compressing the spinal cord from the front. So the spinal cord is pushed backward. So if you come from the back of the patients, you may have a risk to harm the spinal cord when you open the spinal canal. So you see here the tumor that is coming from the neck and that is going inside the spinal canal, and another tumor that is inside the spinal canal and is also pushing the spinal cord backwards. And you see the spinal cord here in blue that is very pushed backwards. And when you know how to operate on peripheral nerve schwannomas, you can operate the lateral schwannoma first, and you go really laterally, and you don't even touch, you don't even see the spinal cord. You take this mass out first, then it allows you to alleviate the compression of the spinal cord, and then you can open the spinal canal and take out the second tumor without any risk to the spinal cord. So it's also a way to operate on schwannomas in NF2 that is, I would say, more adapted to every kind of schwannoma, and that is also very specific of the disease and allows a spinal cord decompression without any harm to the spinal cord. And you see here, for example, the tumor on the right that was compressing the spinal cord from the left. It's on the right on the image, but it's from the left. And when you operate on the spinal cord, you see here the image after surgery. And you see that the spinal cord has, again, a lot of space inside the spinal canal that is surrounded by the CSF, the cerebrospinal fluid. And you can even see that you can manage to keep the small nerve fibers that are coming out of the spinal cord. So it's a very function preservation surgery when you do it correctly with the principles of peripheral nerve surgery that I talked to you about earlier. So the brachial plexus schwannomas, as I told you, there are several cases of multiple tumors in NF2-related schwannomatosis. And for now, we had a limited number of surgical indications because we feel that there's an increased risk of postoperative deficits for those tumors. So if we manage to monitor them for a long time, and if we see that the patient has no pain or no motor deficits, it's something that you can always do without taking any risk for the nerve, because as I told you, when you have a motor deficit, it's mostly due to the neuropathy rather than the schwannoma itself. So we only operated 2 cases of brachial plexus schwannomas in NF2-related schwannomatosis in our department, but with always a good outcome until now. The pelvic schwannomas, so they're located inside the pelvis on branches of the sciatic and femoral nerve. And you see here all the nerves that can harbor schwannomas in the pelvis on this drawing. So they're revealed by either a sciatica or cruralgia, or a pain in the thigh. But as other peripheral nerve schwannomas, they're amenable to a gross total resection with a good outcome. And we operate them via an anterior approach on the side of the lesion. It's a surgery that we do with two surgeons, one vascular surgeons, because you have sometimes to do a deep vascular dissections on the vessels that are around the schwannoma, and the neurosurgeon myself just to take the tumor out once it has been exposed by the vascular surgeon. And it's most of the time a 4-day hospital stay for this kind of surgery. Specificity also of NF2-related schwannomatosis is the case of multiple tumors because it's sometimes very difficult to know on which tumor operate. So it may be the case when you have several tumors at the same spot. So here, for example, a patient has the right L5 sciatica and she has a tumor inside the spinal canal that you see here on this MRI image, but also just below, she has a tumor inside the nerve on the right side. So it may be difficult to know which tumor operates. And in this case, for example, I chose to take the two tumors out at the same time to be sure that I would alleviate the patient pain. But sometimes you have even more difficult cases. For example, a patient with another sciatica that had also a tumor inside the spinal canal at the level of L5 that you can see here. But she had also a lot of schwannomas in the thigh along the sciatic nerve that you can see here. Though in this case, it's also very difficult to know which tumors exactly is causing the symptoms. So most of the time, we try to operate on the more threatening tumors, which means the tumor that is in the spinal canal here. But it's sometimes still very difficult to know which is the best option for the patient. So take-home messages for this presentation. Surgery remains an effective first-line treatment in most cases. You have to be very careful when you deal with multinodular tumors and perineuriomas. And the radiologic clinical correlation is more difficult to establish in NF2-related schwannomatosis because you have multiple tumor locations on the same nerve trunk and you have the associated neuropathies. And as you see, it's a very complex pathology with several kinds of tumors, with lots of locations, with associated neuropathies. So I think there is a big role for tertiary reference centers to handle this pathology and to be able to give the best advice and the best treatment to the patient. So I have now finished with the first part of my presentation that was dedicated to NF2-related schwannomatosis. I really don't know if I have more time to give you a small presentation of non-peripheral nerve tumors in NF2-independent schwannomatosis in case there are patients or families that are dealing with this other disease. Maybe I will go on very quickly because it's a lot shorter. So it's a presentation that I did at the CTF meeting in 2023 that was dedicated to NF2 independent schwannomatosis. So it was a small summary of something that I already told you for NF2. And here it's also a small summary of the management of those peripheral nerve tumors in NF2 independent schwannomatosis, which is exactly the same than what we do in NF2. So here in this series, I presented 59 patients with a mean age at diagnosis of 50 years. Those patients, of course, had a lot less vestibular schwannomas than NF2 patients because they have NF2 independent schwannomatosis, and they had 53% of spinal schwannomas. So as you see on those drawings, there were mostly cases of diffuse schwannomatosis, but there were also some cases of segmental schwannomatosis, and they were mostly sporadic and linked to the LZTR1 gene mutations. So I operated 98 tumors in this condition, including 96 schwannomas and 2 hybrid neurofibromas and schwannomas. So those were mainly located in major nerves and mainly in the lower limb, as you can see on the right. And as in NF2-related schwannomatosis, you had a majority of mononodular tumors, but also some multinodular tumors. So we had 89% of complete tumor resection, 87% of complete pain relief, and 8% of postoperative motor deficits, 13% of postoperative sensory deficits. So the results are quite similar to NF2. We have maybe a little lower number of pain relief and a little lower number of complete tumor resection. So as you see, and as in NF2, there is a sharp difference between mononodular and multinodular tumors. So you see below a mononodular tumor, so you can clearly see the nerve fibers going around the tumor. So it's quite a straightforward surgery when you take the tumor out and you of course you preserve all the surrounding nerve fibers. But when you see a multinodular tumors on the right, it's more difficult because you have to take several nodules out, as you see here. But in the end, you may cause motor deficits, and you see that the rate of motor deficits in those multinodular fibers, it reached almost 40%, and compared to mononodular tumors, where it was, of course, very rare. So it's also something that you have to take into account. Of course, there were limitations to the study because the patients are at a rather low tumor burden. And you can see on the right a patient that has a severe schwannomatosis with a lot of schwannomas. So for those kind of patients, unfortunately, the surgeons cannot do a lot of things because it's not useful to take out a few schwannomas. And those patients that I operated on, they had quite easy anatomical clinical correlation and only 20% of diffuse neuropathic pain, which means that we had a good effect on the pain because it was in most cases linked to the schwannoma. As I told you, there are in schwannomatosis other tumors which are caused hybrid neurofibromas schwannomas, and you see an example here. But for me, those are handled quite like schwannomas, so it's not a big deal if it's an hybrid tumor. So in schwannomatosis, as in NF2, surgery is effective. The indication has to be based on radicular pain. You have to have a sufficient compression of normal nerve fibers, meaning that it's not useful to operate on a small schwannoma because it will not compress the nerve enough to cause the pain. You have to have a good radioclinical correlations, and you have to operate, if possible, on a mononodular and unique schwannoma. And surgery is safe, of course, if it's performed under microscope with nerve monitoring. You have to use the normal fiber preserving technique that I talked to you about. And of course, we exclude multinodular schwannomas if possible, but sometimes we have to take them out also. So I have finished. So thank you very much if you stayed until then, and I'm open to try to answer any questions.
Thank you, Dr. Peyre. Yes, we have some questions. So I will start with the questions that have been sent during the webinar, and then we have also questions that have been sent when people registered. So one question about multinodular schwannomas, are they usually on different fascicles, different fibers, or they are on the same one?
No, I've never seen a case in which all the nodules were on the same fascicle. So all the cases I have seen, but I have not seen all cases, of course, because those are quite rare. But all the tumors were on different fascicles, even when they were very close to one another. And for me, in my opinion, it's why we are causing more deficits when we operate on those tumors, because sometimes the tumor is so big that we want to diminish, to decrease the tumor size, because sometimes it's painful or it's a discomfort to the patient. But when we're decreasing the tumor volume, we're taking sometimes maybe too many fascicles, and it's causing some deficits.
Okay. A question about the pelvic tumor. Are you usually waiting for symptoms before intervention? And also, what type of symptoms do you really have with a pelvic schwannoma?
So for pelvic schwannomas, I also wait for symptoms because it's a more invasive surgery. So it's not like when you open the skin on a arm, or so you have to do a retroperitoneal approach. So you have to be very sure that it will be helpful for the patient. So I wait for symptoms. You can wait quite a long because it's not the case in NF2, but in sporadic pelvic tumors, sometimes the tumor they reach like 8, sometimes 10 or more than 10 centimeters of diameter before causing symptoms. So it means that if you wait, it's not a big deal because there's a lot of space in the belly. So it's not like the spinal canal where you cannot wait. And as for the symptoms, most of the times where the tumor are located on the branches of the sciatic nerve, it will be sciatica, but not cause, of course, to a lumbar disc herniation, but to the tumor itself. But when you have very big tumors, it can also cause some more diffuse symptoms like pelvic pain or like difficulties, bowel difficulties, to go to the toilets. But it's mostly when you reach a very high tumor volume. But I've seen that not in NF2, but in sporadic pelvic tumors. I've seen some cases like that.
Okay. And regarding muscle wastage, I think you talked about it a little bit, but from what you said is the muscle wastage is not always because of a tumor. It's
Yes.
because of yeah.
Yeah.
Because of a tumor, or no? Usually it's not because of,
No, usually it's not linked to the tumor, at least in my experience. So if you have, like, for example, a massive multinodular schwannomas of the brachial plexus and you wait, for example, like 30 or 40 years, maybe it will finish to cause some difficulties in the corresponding end. But when you look at neuropathies in NF2, what is very peculiar is that mostly it's bilateral. So if when you have muscle wasting, you have muscle wasting in both hands, for example, and when you look at the brachial plexus, you don't have schwannomas in both brachial plexuses. So it's not linked. We know that it's not linked to the tumor. So that's why you have to be very careful as a surgeon, because if you tell the patients, I will stop the muscle wasting by operating this or this schwannoma, most of the time, at least in my experience, it won't work. So it's something that you have to be very cautious about.
Another question from a patient is why some of these benign tumor or schwannoma are more painful than others that are not painful at all. What makes them painful? What makes their location being more painful?
So it's a very good question. Actually, I don't know, and I think nobody knows because it's sometimes not linked to the tumor volume itself. Because patients they describe variations in their pain when sometimes on the MRI the tumor volume remains the same. So really, we don't really know. I think that as a surgeon, when you want to suggest surgery to a patient, you have to be sure that the tumor has a certain tumor volume. So it's very rare that we operate on tumors of less than 1 centimeter of diameter because most of the time it's not big enough to cause compression to the nerve fibers and cause pain. But sometimes for the same tumor volume, you may have asymptomatic tumor and very symptomatic tumors. So it's very difficult to tell. My guess is that it's not always the same nerve, even though you have the same location. For example, when you have a big schwannoma in the buttock or in the thigh, it may be on the sciatic nerve itself, and it will cause maybe a lot of pain and it may be to a small sensory branch of the sciatic nerve that is going to the skin. And even if it's very close to the sciatic nerve, it will not cause as much pain. So you have to take into account the parent nerve on which the tumor is located. You have to take into account the side of the tumor. So it's a complex question, but the definitive answer is that nobody knows why it's causing pain.
Okay. If there is a peripheral tumor that are not causing big problems, so that's a question of patient, but they interfere a little bit with the day-to-day life. I mean, is it something you consider for surgery
Yeah,
or
yeah. As I said, it's always a benefit risk balance, So if the patient has some discomfort, for example, sometimes you have small tumors that are next to the to on the foot, next to the part that is touching the shoe. So it's always causing some discomfort when you take your shoes on or off. You can consider taking the tumor out if the patient feels it's enough discomfort in daily life. So it's really we care about the patients and we listen to the patient and we also discuss with the patient the risk, because if it's on the major nerves, we are less prone to do surgery. But if it's on the small nerve, we are more prone to doing surgery, even I would say for a small discomfort. So it's always a balance that we have to discuss.
Yes. Okay. And you said also that you don't recommend to operate on a small tumor, so you prefer to have the tumor to let it grow
Yes.
a bit. So that's a bit different than, for example, sometimes with the vestibular schwannoma, where you don't want to
Yeah.
let it grow too much. But here, in the case of peripheral schwannoma, you prefer to let it grow because it facilitates the way you will do the
Yeah.
surgery. Or
Yes, sometimes when I had to operate on small schwannomas, I saw that during surgery it's more difficult to dissect the tumor from the normal nerve fibers because when the schwannoma is small, the fibers may be all around the tumor, and when the tumor grows, it kind of spreads the fibers apart that open like I would say a flower, and you can have the tumor on the top and the nerve fibers on the side. So it may be safer for the patient if you wait a little more until the normal nerve fibers are spread apart by the tumor. And of course, it doesn't give any additional risk because as you understand, the main part of the surgery is finding the right plane. And when you have the right plane of dissection, you know that if you respect the plane, you don't have any risk of harming the normal nerve fibers.
And can you see these nerves on the imaging before
Yes,
surgery?
yes, it's something that I should have shown during my presentation, but I went a little too quick. But on some sequences on MRI, you can see the normal nerve fibers on one side of the tumor. So you can sometimes even before surgery know where the normal nerve fibers will be, and it allows you also to do a I would say an efficient dissection of the nerve to go on the side of the schwannoma where you won't see any normal nerve fibers. So it's something that you can see. It's not always the case, but it can be seen on MRI actually.
Okay. Another question, someone from Australia, but I think it's a general question as well, is asking if a clinician, doctor in some in countries around the world can contact you to share their case with you. Is that something
Yeah, yeah, of
you?
course.
Yeah. Okay. So um, we make sure that so for anyone that wants to have that have a doctor that will have to be in contact with an experienced peripheral nerve surgeon like Dr. Peyre, you can send us an email to NF2 BioSolutions and then we will pass the information to Dr. Peyre. And then last questions about drugs. So I know there is not that many drugs that currently are being, and you touched on the Avastin a little bit, but currently people are taking Avastin or brigatinib or in the past everolimus. From your experience with peripheral nerve, did you see anything particular with this benign tumor when the people were on taking these drugs?
So,
Before.
yeah, it's a good question, of course, but unfortunately, I don't have, I would say, enough experience to answer this because in Paris, at least, we don't give this drug, of course, for peripheral nerve tumors, and we never had the chance to test them just in this specific indication. So we have been discussing with Professor Plotkin to test brigatinib in particular for peripheral nerve pain in NF2 patients. But since we discussed this with him, we actually never had a chance to put a patient on brigatinib for the specific indications. We don't have enough experience on brigatinib, and for bevacizumab, also I don't do the follow-up of patient myself when they're on bevacizumab. It's done by the neuro-oncologist. So I may not have the best, the best point of view to answer this question, but maybe some neuro-oncologists have seen some effect on some peripheral nerve tumors or some peripheral nerve tumors associated pains, but not that I know of, unfortunately.
Okay, okay. But thank you very much, Dr. Perez. It was very informative. and this has been recorded and it will be published. And we know that in the next few months there will be hundreds and thousands of views of this recording. So it's very, very useful. And I know many doctors are watching these recordings as well. We see based on the people that are registering. So thank you so much again.
Thank
And
you.
and we will be in touch if there is any questions, any follow-up that will pop up. Yeah.
Then don't hesitate, and thank you once again for the proposition, and I hope it will be helpful for patients, families, and doctors alike.
Thank you very much. Have a good night.
Have a good
Bye-bye.
night. Bye.